Hello, my name is Cameron Sabat, and this is Cutting to the Case. Today on Cutting to the Case, we're joined by Mark Cuban, one of America's most recognizable entrepreneurs, investors, and philanthropists. Best known as the owner of the Dallas Mavericks and longtime investor on Shark Tank, Mark has built a reputation for disrupting established industries with bold ideas. His latest venture, Mark Cuban Cost Plus Drug Company, is tackling one of the most pressing issues in American healthcare, the skyrocketing cost of prescription medications. With a transparent direct-to-consumer model, Cost Plus aims to reshape the way patients access affordable drugs. We'll explore his vision for lowering drug prices, his philosophy on healthcare innovation, and what comes next in his journey to make medicine more accessible. Thank you so much for joining today.
Thanks for having me on, Cameron.
Yes. So you've said that, Cost Plus was born out of frustration with opaque pricing. What was the exact moment you realized the only way forward was building your own drug company?
I mean, looking what happened with the pharma bro, Martin Shkreli, and the
Mhm.
fact that he was able to take this drug Daraprim and jack it up to obscene levels made it obvious that something was not right in the pharmaceutical industry. And so it was an opportunity for us to create an alternative model, and that's why we created Cost Plus Drugs, with the whole foundation being transparency. When you go to costplusdrugs.com, you put in the name of the medication, and if it's one of the 7,200 that we carry, we'll show you our actual cost. And then we'll show you our 15% markup. And by knowing those two things, we're not taking advantage of you, that we're being fair. And that's led to millions of people using us.
Mhm. And really, PBMs are often painted as villains, but they also wield enormous lobbying power. Have you seen examples where they've directly tried to shut you out, and how do you counter that?
Oh yeah. Oh yeah. I mean, there's certain drugs that we don't have, and the only reason we don't have them is because those manufacturers told us they were concerned that the PBMs would diminish them on their formularies. The formulary is the list of medications that the PBMs cover, and they do that for 180 million, give or take, people. And so the big brand manufacturers, they're not going to risk access to 180 million people just to make their medications available in cost plus drugs. And that has been our biggest challenge so far.
Yeah, that's huge. And really, I heard a lot about that. I was originally introduced to Cost Plus a while back through the Nejm podcast. The New England
Uh-huh.
Journal of Medicine covered you.
Yep.
Your brand is great at generics, but biologics and GLP-1s are where the real financial battles are. Do you have a concrete pathway to move into those categories, and what would force your hand?
So a couple things there. One, we work with biosimilars now. So we have Yusimry, biosimilar for Humira. We have one coming up very shortly for Stelara, and many, many more. So, not only will we be selling biosimilars, but we can make them as well. We can actually manufacture them. So that'll be one path. Um, in terms of GLP-1s, we're in ongoing negotiations and discussions with the manufacturers. And as some of those get more competitive, like we have some GLP-1s that aren't the big names, right? Victoza and Brinzavi and some other ones that work and are very popular, but we're still talking to the big brand name GLP-1s and working on that. And in terms of biosimilars, same brand issues there, but there's a lot of the new ones that are coming out where they want to work with us because the PBMs are picking winners and losers. And if you're not the one company that they picked, everybody else is going to work with us.
Yes, yes. And kind of transferring toward working with you as well, building those partnerships. A lot of companies pitch affordability, but flame out when they can't build trust with physicians. And actually, I spoke with a physician at Georgetown. I'm a Georgetown medical student about why not use Cost Plus, and they were saying that it's maybe 80 milligrams instead of 81, and so they're concerned about the
Yeah, that's an
efficacy.
excuse. That's an excuse.
It,
You
it,
know,
it does sound like it. I
yeah,
was
I mean,
wondering
there's
what's
whatever the normal, whatever the skew is, the NPI, I forget, not the NPI, I forget the exact term acronym, right? Because there's so many acronyms, but whatever the skew is for that medication, if it's readily available, we make it available. And on top of that, through our manufacturing, um, we make sterile injectables that are in short supply.
Mhm.
So there are going to be pediatric cancer drugs. There are going to be Pitocin, sterile water, all these different things that typically go on short supply that we'll have available. And if it's something that we can manufacture, we'll make it to whatever we can make it to whatever specification. So the fact that they're not using it, I bet they've never really actually checked, and it's costing Georgetown Medical a lot of money that they haven't checked.
Certainly. And really, you are a billionaire taking on entrenched healthcare giants. When considering Georgetown and, unexpected pushbacks, what conversations behind closed doors have surprised you the most? Either hostility or unexpected support?
Not really a hostility, but more that, to your point with the doctor, where, they'll talk to somebody who works with a PBM, and the PBM will give you, the one line, well, they can't get it, this size and they have it in that size. I'll give you another example for our Humira biosimilar. There's a huge, huge, huge company, one of the biggest in the world. And I was like, here, compare our price to your price for this Humira biosimilar. And we were significantly cheaper. And I'm like, well, why won't you buy from us if we're significantly cheaper? So they went and spoke to the PBM who said, and remember, this is a biosimilar, it's the generic injectable. And the PBM told them, and they believed them, that this biosimilar only worked 20% of the time. Well, if it only worked 20% of the time, it would not be a biosimilar, right? It would not be FDA approved. It was just all nonsense. But that's what happens a lot. The PBMs will put out their, misinformation, knowing that if they don't, these companies are going to switch, and Georgetown Medical, whoever it may be, are going to switch and buy from us. We have this organization called Cost Plus Marketplace. So if you go to business.costplusdrugs.com, you'll see it. And we sell wholesale injectables and you name it to clinics and hospitals. We did a deal with Penn Medical and we saved them $4 million a year. We did a deal with CHS. We saved them over $1 million a year. And the list of examples like that go on and on. And what happens is you get hospitals, networks, et cetera, they just get so set in their ways that their purchasing agents don't want to make any changes whatsoever. And so every single time, without exception rather, where we've done an analysis of claims or analysis of purchasing, we're always cheaper. And it's just insane to me that big hospitals like a Georgetown don't even check. They just do it the same way that it's always been done. And during a period of time where saving every dollar is huge for every hospital, every teaching school, whatever it may be, now is the time really to work and see if you can save money. And we're there for them. So have them go to business.costplusdrugs.com and we'll get you our price list.
Wow, that's incredible. And kind of moving forward as well, if you could force the FDA, CMS, or Congress to make one regulatory change tomorrow that would cut drug prices, what would it be?
Segregate formularies from PBMs.
Hmm.
Because the big PBMs, the way they use formularies is to build up a number of lives, right, where they have market dominance, and then they auction off access to that formulary. You saw it with CVS and their approach to GLP-1s, where they went exclusively with Novo Nordisk. I mean, just think about that. There's not, not no one GLP-1 covers all indications. There's doctors are going to make a determination what's best for their patient, and to have the PBM determine what's covered and what's not, that's just insane. And so by segregating the two, divorcing the formulary from the PBM and letting organizations, whether it's, Georgetown, whoever it may be, work with consultants or internally to put together their own formulary, you'll get better matching to the population that you're trying to support. And it won't be purely an economic exercise like it is right now.
Hmm. Hmm. And additionally, Cost Plus is already succeeding wildly. But if it continues to succeed wildly, what would a realistic end game look like for you? I mean, IPO acquisition, permanent
No,
operation.
no, none of that. I don't need more money. My mission is just to fuck up healthcare. That's it. I've got more money than I could ever spend, than my kids could spend, than their kids could spend. So I'm not looking to bring in investors. We get offers all the time. Not looking to go public. We're a public benefit corporation. I just want so that we have complete transparency across all healthcare. Healthcare is a really easy business, right? Doctors do what doctors do, right? The healthcare side isn't easy, right? But that's why you're trained. That's why there's technology, etc. You guys do your best for patients. But once you make a determination that a patient needs something or doesn't need something, if they do, there's only two questions. What does it cost and how do you pay for it? We spend $5 trillion making a mess of what does it cost and how do you pay for it.
Mhm.
And a big part of that is because of the vertical integration of the biggest insurance companies and the biggest PBMs.
Mhm.
You cannot possibly align the interests of patients and maximizing profits.
Mhm.
I don't mind if companies make profits, right? But if you're doing all you can to maximize profits, your interests are not going to be aligned with patients because you're going to take steps that will, increase the cost rather than minimizing it like we do. Like we're trying to make money, but you're going to know my markup and it's going to be transparent. If you think it's fair and hopefully it'll be the least cost, you'll deal with us. And if not, that's fine too. If somebody else is cheaper, more power to you means that we're doing our job of making medications cheaper.
Mhm.
So the end game is to completely disrupt the insurance and pharmacy industry. And I think there's a path there because when I go to companies and say, look, you should add cost plus drugs to your network, I'm not saying spend more money.
Mhm.
I'm not saying, put your patients, your members' wellness at risk. I'm saying the exact opposite. If you determine that this is better for the health and wellness and economics of your company and your employees and their families, use us.
Mhm.
But don't fool yourself into thinking that everything a broker, consultant, PBM tells you is accurate. We're here to help you do the homework and let's get to the bottom of it. Let's be transparent and find facts. We've been shipping 3.5 years now, and we are still the only pharmacy that completely publishes their price list. Nobody else does that. And it's insane when you think about it, because it's the simplest of all things to do. It's easy, easy. Doesn't require paper. It just requires spreadsheet lines. It may be a PDF. Anybody can do it. And it's not just for patients. Going back to Georgetown, right? And the hospitals, they're not buying at the best price. I was shocked at the premiums that hospitals, big and small, pay to buy injectable products. It was just like ridiculous. And that leads to this quagmire with, what's medical benefit versus pharmacy benefit, 340B. All these issues arise because I'll take one step to the side here. Think about how insurance plans are set up, right? You have an insurance company that makes the determination that they're going to have multiple plans that have a component that's premium and a component that's deductible, right? Deductibles are going up. Do you know what your deductible is for your plan?
No, actually, I have Blue Cross Blue Shield.
Okay, that's okay. But those deductibles on average are going up, whether it's for corporate, whether it's ACA, whether it's Medicare Part D, whether it's Medicare Part A and Part B, except they're going up. You know what never happens on those deductibles? No one ever does a credit check. No one ever makes sure that the people making those determinations can even afford it. And so if somebody can't afford their deductible, and we know that 40% of people in this country don't have $400 in savings. And if you take out the people on Medicaid, it's, probably 30% of people that don't have $400. Well, if they don't have $400, they're not going to be able to afford their deductible. If they can't afford their deductible, they can't get health care.
Mhm.
And so we have these huge insurance companies that are defining the plans, even within the ACA and to a certain extent Medicare, Part D particularly, that are defining these plans and making the determination, knowing that most people, as they increase deductibles, won't even be able to afford them. So what's the second order impact? So now these people get sick and they have to go to the hospital. They can't afford the deductible. So what ends up happening is that the hospital loans them money because they still have to care for them at some level, especially if they come to the emergency room. And, so they want to take care of them. And so they loan them money or put them on a plan. And so now we've turned hospitals into subprime lenders.
Mhm.
And so you've put all this onus on the hospital to generate that revenue to cover, the care that they've just provided. And that makes them have to invent new sources of revenue to compensate for the lack of alignment that the insurance company plans create. And think about it. The hospitals and all providers, you in your future as a doctor, are going to accept giving care to patients that can't pay for it. And you have to make determinations how you're going to deal with that. And yet you have no say in any of the process. Is that right? No, we want, so this whole system, again, it's easy business. The whole system on the side of how do we determine healthcare plans, deductibles, how they're paid for. We can't just leave that in the hands of the biggest insurance companies. And not only that, like we see what's happening with ACA premiums now with all the changes, right? Those are approved, those plans are approved by the government, right? And are managed and run by big insurance companies. Not all of them are as big as others, but managed run by insurance companies. And now they're just trying to survive. So you've got this far less than virtuous circle, right? Horrific circle that sucks a little bit from everybody, particularly the patients, and is not designed to the point where anybody's interests are aligned. And we've put complete control in these big insurance companies. That needs to change, and that's the mission I'm on.
And that changes through business and private
It changes through business, it changes through education. Because, I've never heard anybody discuss the fact that all these deductibles and nobody ever knows if the person that's signing up for that plan can even afford the deductible. We just let them do it knowing, and I've been there myself. If you look at my hands and how messed up they are because I couldn't afford insurance and deductibles, right? I've been there. So when we don't have money and we're broke, we pick the lowest premium and the highest deductible and just pray to God nothing goes too wrong. And so, that's the problem. That's the underpinning problem. Everything flows down there, and those same big insurance companies that determine all of this own the PBMs that determine the costs. That's the challenge we face.
That's a huge problem. And you're doing the Lord's work here, really, really helping out.
Trying. We got a long way to go, but we're trying.
Huge, huge. So yeah, I really appreciate you sitting down for this podcast. I promise to maintain your time. Really, just last takeaway for the listeners.
Sure.
I mean, a lot of the audience are fellow medical students and trainees. What can we do, and what's some advice that you have for us moving forward? Us, entrepreneurial minded, medical students as well.
Well, first, thank you. That's why I did this podcast, because we don't have enough doctors. We need more doctors. We don't pay you guys enough. We need to pay doctors more. We saddle you with too much debt. That just makes your decisions more geared towards your economics, unless you can just afford to do it. So follow, my hope is as we evolve a lot of these things for doctors, you guys follow your heart and help the people that that need help, as opposed to just going into specialties that just pay the most money. We need as many primary care doctors as we can get. And then I'd also tell you that look for new places to go to work. I know you got to do your residency and all that, but after that, there are companies that hire doctors. And that number of companies is going to grow because they have populations that are aging. The workforce is aging, their families are aging, right? So there are unique opportunities as opposed that where you can probably get paid more and focus more on care than just going into the traditional grind of going to work at somebody's practice that just got bought by a PE firm that just got bought by, a big insurance company. So there are alternatives out there. Find the path that makes you feel best.
Absolutely. And thank you so much. You're really an inspiration to me and my colleagues and a lot of my high school friends even as well.
Appreciate
So
it.
I thank you so much.
Appreciate
Yeah,
it.
this
Thanks,
is Cutting to
Gavin.
the Case. This is Cameron Sabat signing off.